Hey, everybody, and welcome to Community Conversations. My name is Luke Margolis. I'm the Director of Corporate Communications here at Atlantic Health System, and thanks so much for joining us for today's program. Today, we're going to be talking about something super important in the month of September. Obviously, for everybody who follows these types of ceremonial healthcare months and kind of sees those things on their calendar, September is Prostate Cancer Awareness Month. It's a critical topic for folks really of a wide array of ages. You're going to learn a little bit more about some of those folks in particular who will be particularly focused on this. But to have this conversation, I'm excited to bring in somebody who I've worked with quite a bit in the past here at Atlantic Health. He is a wealth of information on this topic and really a critical part of our efforts to keep people prostate healthy, we'll call it. That's Dr. Prasad. Dr. Prasad, good to see you, sir.
Luke, thanks so much. Thanks for having me today. I really enjoy this topic, and I'm really happy to spend some time with you talking about it.
Awesome. Dr. Prasad is the Director of Urologic Oncology here at Atlantic Health System. He's the Vice Chair of Urology at Morristown Medical Center as well, part of Atlantic Health. So you know we've got the right expert in the room. Just before we really tuck into our specific subject matter, just a broad programming note. If prostate health is not exactly the topic you're interested in, but you want to learn about pretty much anything else going on in your body or in healthcare, go to atlantichealth.org. We've got a ton of information on there for you. We've got other programs like this that you can find links to. You can also subscribe to our YouTube channel if you want to see those types of things. But you can also get in touch with doctors from a myriad of disciplines. Go to the Find a Doc button there on our website, and anybody you're looking for, urologist, OBGYN, cardiologist, anything you're looking for, you can find just a click away on atlantichealth.org. All right, Dr. Prasad, that's my programming note. Let's get into it.
That's great. Let's do it.
All right. So prostate health really is the overall topic we're talking about, but September really is Prostate Cancer Awareness Month. And when we talk about awareness for these types of conditions, we're often talking about screening, but there's a lot there. What are some of the things you think about when you think of a ceremonial month like this?
Yeah, and I think there's been a really important change from the initial naming of this month, which was Prostate Cancer Awareness Month, into Prostate Health Awareness Month, because for many men, urologists are the entree into their healthcare experience.
Oh, that's
right. They've seen a pediatrician perhaps when they were younger with their parents, and then really without medical problems they're aware of, they may not see a doctor regularly. And that's a bit different than women who often will see a gynecologist as part of their care in their 20s, 30s, and even into their 40s. So for many men, we encourage you to come and see us as you begin to enter the decades of your 40s and 50s, as we begin to talk about all issues that begin to affect men at that time. So that includes things like voiding issues, erectile dysfunction, and then of course we also include prostate cancer screening as part of that.
Voiding issues being urination.
Yeah, urination issues primarily, and those are the types of things that we see. But again, many men will come to us for the first time with testosterone issues, erectile dysfunction. But again, we sort of welcome men into the space to say, listen, come to us with really any issues you think we can be helpful for in the general urinary space. And a lot of those are kind of the core things that first affect men from a healthcare perspective. So we can kind of go from those types of topics into just a general men's health or prostate health awareness approach. And again, the core of that for us as far as this month goes is in regards to prostate cancer screening.
And what, I'm interested in that dynamic, right? When you have patients who come in for the first time and perhaps they've been out of the healthcare experience for 5 years, 10 years. I over a recent weekend, I was talking to a friend of mine. He's like, I really haven't had a checkup in years, right? Do you find that often that with men, you're starting from somewhat of a baseline level of understanding about their own health and wellness?
Absolutely. And I can tell you that probably on any given day, I'll write on the back of my business card the name of a primary care doctor.
Because they just don't have a relationship.
They literally have never had a primary care doctor, but they're seeing me for the first quote unquote bother they've had in their adult life.
Sure.
And so again, while we can tackle that, we also want those patients to sort of tackle back into cholesterol and blood pressure and all the other things that are really important for men to focus on. And sometimes those are also the causes of why they have issues with, for example, erections.
Oh, right.
Right, because that's a cardiovascular problem of that particular organ, but it can kind of lead to signs for things like diabetes, for example, and so can voiding. So again, we can sort of be the entree back into a traditional healthcare experience. But again, we're happy to see that patient up front, address the issue that they kind of came into the office with, and then help them sort of transition back into a more traditional approach to healthcare care, really.
One more on motivations, and then we can get into some of the tactical stuff that we do. Conversations I've had with oncologists on this program specifically, but with other physicians as well, sort of comes back oftentimes to one central point that folks, I guess we'll call it out of sight, out of mind, they don't want to know, right? Maybe there's something wrong, and it's just, there's nothing wrong in their minds until somebody tells them there's something wrong, and then all of a sudden something's wrong, right? How much do you combat that as a physician in terms of this notion of, I just don't want to know. It's too scary to even think about.
Yeah, and I think that's a fair question. I think you're right that that's actually quite often why men specifically, but I think many people sort of avoid the healthcare system. And again, my answer to that is, let us help you be aware of what's going on. And many times it's reassuring, right? Many times it's to confirm that you are doing well, and those things are all in line, whether it's your cholesterol, blood pressure, and other health issues that are easy to follow. The problem with waiting for symptoms, and again, is that most of these sorts of things, the symptom is a big problem, right? The symptom of having high blood pressure is a stroke.
Yeah.
The symptom of having high cholesterol is a heart attack.
Right.
It's not something you're going to feel otherwise. And the same thing is true for screening for men. For prostate cancer, the first sign, unfortunately, for many men of prostate cancer may be disease in the bone that begins to be symptomatic or painful in a bone. And by that time, we're not going to be able to help the patient towards cure. We're really working on disease control.
Right.
So if a man comes to me because he has erection issues, but really that taps back into the fact that he's got cardiovascular issues, and this is the first sign, let that be the first sign, right?
We're lucky in the coal mine.
Yeah, we're lucky to have that be our first sign. One is because we're very good at helping with that condition. But secondly, that can help us get back into, okay, here are some of the root causes of why some men have erectile dysfunction. It may be that they have really high blood pressure, poorly controlled diabetes, cholesterol problems, and it's just manifesting for the first time as a cardiovascular condition of this particular organ.
Got it.
Right. So again, we like all comers, right? And we're very good at sort of helping you to that visit there, but not berating you about anything, but saying, listen, we're going to tackle this today. Let's go back and just make sure we're sort of hitting root causes as well.
Yeah.
And that's sort of part of what a urologist does, is we really bridge between being a specialist, but again, for many men, being their first entree back into the healthcare system.
Yeah, the gateway back in.
Yeah, we're the gateway back, and we like that role. I think urologists really enjoy that continuity of care. I see many patients on an annual basis, some of which are for cancer follow-up, but many of which are for other issues that are benign.
Yeah.
And again, I enjoy the fact that we get to help acutely for really significant issues sometimes, like a severe cancer diagnosis, but also that we have continuity of care where we see patients annually, sort of as their general men's checkup.
Build those relationships.
Yeah, and that's really fun, right? It's fun to be able to participate in both of those spaces together.
And hopefully for folks out there who are listening who maybe don't have those relationships, there's something reassuring about that notion of really finding a physician who knows you and has your experience over time, and you build that collective relationship. That's a point that often comes up on this program. So, okay, let's pivot into the tactical, right? So let's say you have a patient who comes into you for the first time. Maybe they've got a family history of prostate issues, perhaps not. What are some of the early steps you take in helping assess those patients? And then and I guess we can tap into really the one topic we talk about a lot, which is screening, right? So how do you begin to unpack what a patient may be dealing with?
Yeah, so I think that there's really three primary areas that when we see a patient for the first time, we're making sure, and a man specifically, obviously for women, we do similar types of things, but for the purposes of prostate cancer and prostate health, there's really three things we'll tackle in any man, no matter what you walk into our office with. One is to get a sense of what your baseline health status is. So that's the same history and physical that you'll have in every office. So we're checking things like blood pressure, making sure that sugars are under control, all those sorts of things. We're going to ask you about urination. And these are, again, topics that men may not talk about, or you really may not know what the norm is for a patient. You're not standing next to the urinal and staring at the guy next to you to see how well this
conversation you have.
But it's helpful. We have really objective ways of sort of understanding where you are relative to men your age.
Okay.
And then a lot of it's reassurance. You're doing fine. I know you noticed this for the first time, but you're okay. You're well within the bell curve of what we expect, or you're not.
Yeah.
We always ask about erection issues. That clearly is something that many men have some discomfort bringing up on their own.
Yeah.
So some men will come to us for the first time and say, listen, I'm here for you to help me with my erectile dysfunction. But many men come in with another complaint, and it's sort of the end of the visit, they may loop back into it. I'm very proactive. I'll ask them about that. I'll let them know at the very beginning, hey, we're going to talk about the issue you came in for, but we'll make sure we cover these other two topics as well.
Right.
And really, there's probably no better safe space in general than seeing your urologist talk about those issues. And then finally, for men of the appropriate age, generally 40 and above, for men who have a family history of prostate cancer in a first-degree relative, so a brother or a father. And then really around 45 for any man who has a family history of any hormonal cancer. So this is kind of one of the new things we're learning, is that breast cancer or ovarian cancer in your mother may be a hormonal link to prostate cancer. Oh. And so again, it's not just what your dad or your brother had. It's not just prostate cancer anymore. Prostate cancer turns out to be really in a family of hormonal cancers for which women have their own as well. So a mother's history of ovarian cancer in their 40s is really important for a man to be aware of and to come see us sooner. Traditionally, if you have no family history, we generally tell you to come to us and start screening at age 50.
Age 50.
And again, that's really a really easy visit for us. So typically we just do a men's exam, which takes us about 2 minutes or so to do. It's an area where sometimes men are concerned about the comfort level of this. Again, it's something we do very frequently. And so it's something that just takes a few minutes. We do it typically once a year, and it provides us reassurance that from a physical standpoint, everything looks okay. And then really one blood test called a PSA blood test.
PSA?
Yeah, so PSA stands for prostate-specific antigen. It's just a chemical in the bloodstream. It's a simple blood draw. And again, we typically recommend doing that once a year at the beginning. But then like your colonoscopy, if the number is lower, we can often say come back in 3 years or even 5 years for those types of checks, as long as we know at baseline you're doing okay. Right. So we used to do this annually, but again, we've learned to what we call risk stratify patients, that if you don't have a lot of risk factors, you may not need the same intensity as someone, for example, whose father had prostate cancer. So again, everything is really individualized, which is nice. But again, 40 years old with a first-degree family history of prostate cancer, typically 45 with any family history of any hormonal cancer, female or male.
Yeah.
And then age 50, if really you're fortunate enough not to have any of that type of history. But really, in any of those scenarios, we're happy to see any time.
Right. Yeah. And there's a peace of mind that comes from knowing, being consistent, being checked up regularly, that you're doing okay.
Correct.
It's something we would love. Okay. So one of the things we often talk about as we talk specifically about oncology issues is patient journeys, right? When once you enter into our care here at Atlantic Health System, how we wrap services around patients to ensure they get the care they need. In the event, and I think you described it well, where everything kind of checks out clear, you just kind of periodically check back in. What happens in the event that something does come up? How do we begin to marshal resources around people? What's the next step? Because I think, again, it all aligns with that notion of education is power, right? So how do we help people along that journey?
Right. Well, one is we're very lucky. We have a very robust prostate health program. And again, typically that may start with the urologist sort of as what's patient facing at the very beginning. And we're very lucky. We have a very large number of urologists that practice within Atlantic Health. Many of us are specialty trained in urologic oncology, but we also have people who are specialists in the other areas that can be affected by our cancers in the urologic system. So we have erectile dysfunction specialists, we have voiding specialists, and these are all fellowship trained urologists that have gone on to additional training beyond that. And that exists throughout the entirety of the system. So one is we have expertise at the patient-facing level from the urologist. But probably even more importantly, we have an incredible layer behind that, right? We have fellowship-trained pathologists that look at all the slides that are urologic trained. We have radiologists and interventional radiologists that you may not meet the first time, but they're experts in the urologic system to help us for any procedural type approaches. The typical entree is with us or with your primary care doctor to talk about prostate screening. Many primary care doctors still perform prostate cancer screening, and we welcome that. We encourage that. Not all do. And then again, we're a resource for that. If the primary care doctor is not doing prostate cancer screening, we can be that person for you as well.
Do that support.
So again, we're really happy to help out either way. We provide education to the community. We provide education to our partners, who are physician partners, nurse practitioners, PAs, our ER doctors, really anyone who has the opportunity to meet a patient where we can potentially be helpful. But when it comes down to sort of, okay, some of these tests look abnormal, there is an explosion over the past 5 to 10 years of the types of tests that we do beyond PSA.
Oh, okay.
And we've been leaders here at Atlantic Health in many of those spaces, both in terms of research and then in terms of implementation. So for example, 10 years ago, a patient who had a high PSA would typically just go on to something called a prostate biopsy. For men who've had that procedure, let's say 10 years ago, that was a procedure done in the office, often with a little bit of discomfort. Nowadays, we're able to hold off on probably about 50 to 60% of the biopsies we did 10 years ago by using secondary non-invasive tests, like, for example, prostate MRI or other urine-based tests that look at prostate cancer risk. And we can actually not perform biopsies in a significant portion of men, where before we didn't have those tools. And men sort of say, listen, if I'm going to come in, I'm worried I'm going to have that. I tell them, actually, by coming in to see me, the majority of patients like you are not going to have a biopsy. Yeah, right. You can avoid it. Right. But importantly, for those that need it, we do it in a timely fashion. Prostate MRI is, for example, one programmatic area in Atlantic Health that we were leaders in. We had the first prostate MRI program in the state of New Jersey, and we had the first prostate MRI biopsy program in the state of New Jersey. Wow. And again, if you think about the way we used to biopsy, we did biopsies essentially by what we could feel. Right. If we felt something, we did a biopsy. But that exam is just limited to the back of the prostate. It's by virtue of doing it through the rectum. That's how our exam is done. So the top or the anterior part of the prostate is by your belly button. You can't get to that part. So we sometimes would miss tumors in that location because we just couldn't feel them and know to biopsy them. So prostate MRI, which again is about 7 to 10 years old, has transformed us because now we're taking about 2,000 pictures of an organ that's about the size of a plum. And so we have the ability now to be incredibly precise at finding areas where we should biopsy and also to find areas we should biopsy that we can't feel. And that's really revolutionized the ability to understand which patients to biopsy and how accurately we can biopsy them. The other part of it even if you have prostate cancer, 40% of our patients at Atlantic Health that are initially biopsied and found to have prostate cancer, that is, you have a new cancer diagnosis, we observe. That again is a tremendous change from 10 to 15 years ago, where over 95% of patients in the United States with a new diagnosis of prostate cancer were treated.
Right.
How
Surgically?
Surgically, with radiation, those were the two mainstays of treatment, but you got something 15 years ago. So if you got a diagnosis, you got a treatment.
There was something.
Now, almost half of patients who are newly diagnosed, we can tell them by virtue of genetic testing, for example, that we can tell them you have a prostate cancer that is safe to observe. And typically when we talk about observation, our goal is at least 10 years of not doing anything.
Well, that's transformative for people.
It absolutely is, and that's called active surveillance. So 40% of our patients who are newly diagnosed will go on to active surveillance. Active surveillance is seeing me twice a year for a quick exam, a blood test, and avoiding the interventions that prostate cancer sometimes necessitates. Yeah. For the 60%, we know right away you've got one that matters. And that's really where that next step is, that next layer comes in of what are our treatment paradigms. But again, I always tell patients, this is empowering you with the knowledge to understand, A, do you need a biopsy or not? Because we can take some of those right off the table.
Yeah.
Secondly, if you have prostate cancer, do you have one you need to treat or not? We can take almost half of patients and say, you're in a cohort that's safe to observe. We're going to keep an eye on you. We're not going to let this get out of control. We're going to observe you closely, but you don't require intervention today and hopefully not for another 10 years at least.
Yeah.
But then that last layer comes down to how are we helping those patients who have a bad prostate
what happens
cancer?
if you have to really...
Right. And that's, again, that's really sort of that third layer of treatment approaches. And another place where we've really been very quite innovative in terms of opportunities that are offered to patients. So historically, the two mainstays of treatment have been radiation and surgery.
Right.
That's traditionally how about 95% of men in the United States have been treated for prostate cancer over the past 5 decades. So those have been around for a long time. Here at Atlantic Health, we've been one of the first to use robotic surgery now over a decade ago. And in our practice, we haven't performed at Morristown, we haven't performed an open prostatectomy, meaning not using the surgical robot through small incisions in over 5 years.
So this is now the standard of how you do it.
It would be uncommon to do it any other way, and we do hundreds and hundreds of these a year at our hospital alone, and of course many hundreds across the entire Atlantic Health system.
Sure.
So these are operations we are doing daily at this point.
Wow.
More recently, these types of surgeries, patients go home the same day over 75% of the time. So we've now taken prostate cancer to a place where it looks more like a gallbladder or an appendix removal.
Wow.
Patients can go home the same day, typically on Tylenol and Motrin. My patients who have surgery, which I do every week, will leave the hospital the same day of their operation without any prescriptions.
That's a huge difference.
A huge change. Yeah. There still are consequences to our treatments.
Yeah.
And so we never want to diminish it, but the surgical experience has really been transformed first by the surgical robot, and secondly by other pathways we use to really minimize what the patient experience is that day, to allow them to have this basically as an outpatient procedure going forward. That may not be true for every surgeon or for every patient, but again, for the majority, almost 75% of patients in our practice, patients are going home the same day, sleeping in their own bed, eating food at home, the same day they have prostate cancer removal.
Wow.
Radiation also has the ability to really be more patient-focused. So historically, radiation had been given for really 8 to 10 minutes at a session, but it took often 40, 50, sometimes even 60 sessions, meaning patients were coming 5 days a week for even 2 to 3 months at a time.
Wow.
Now we've taken some of those patients down to being treated in 1 week. And so the outcomes are the same for many patients, again, for the appropriately selected patient. And again, because of genetics, MRIs, et cetera, we're better at selecting patients rather than throwing the same fastball at every single pitch,
just
right?
See what happens,
right? Now we can really do what's called patient-specified, right, or personalized medicine, meaning for this individual patient, these are the mutations, these are the abnormalities, this is your MRI, here's what you need, here's your particular cocktail. And for some patients, that's 5 days. Their entire prostate cancer radiation journey, instead of 2 months, is 1 week.
Wow.
And so again, there's not side effects to these treatments, but we've made the experience much better. The other that we've really innovated is we were the first in New Jersey to utilize a really novel approach to prostate cancer treatment, which is not to focus on the whole prostate, which is what surgical removal is and what radiation is, but something called focal therapy. And again, focal therapy is new. It was FDA approved 2 years ago. We have the largest experience in New Jersey with focal therapy. And we're the first to use the program called Focal One, which is the primary way of delivering focal therapy in the United States. And again, this is using ultrasound waves to destroy prostate tissue just in a very small area where the cancer may be.
Focused.
Very focused area. And the benefit there is you're avoiding side effects of treating the whole organ. And so this has become a very robust and important part of our prostate cancer program. Again, it's offered across the system using various technologies. So we use freezing probes, we use ultrasound, we use electricity. And again, there's reasons why we might use one versus the other. But all of this is new as of 2 years ago in the United States. And we've already introduced 3 or 4 different modalities to provide focal therapy for prostate cancer. And that's an area where patients are really excited about this new thing that we haven't had for decades and decades, where they don't see the side effects that they may have heard about or their brother or father had when they were treated 5 years ago, 10 years ago, 20 years ago. And so again, that allows us to bring patients in and say, even though you're having this diagnosis, and it's one we should probably treat, the experience here is going to be one that has side effects that are manageable and may not be what you're afraid of.
Right. Is not through the rumors, the experiences you've seen from other people.
Correct.
Yeah.
Correct.
Okay. So it is, from everything you've described, somewhat of a brave new world in the treatment of this disease. I want to take a step sort of back to go forward here. In looking at all of these tactics and in encouraging people to come in early and have those relationships with physicians like yourself, how successful can we be in treating prostate cancer? Has the success rates improved along with these new modalities, or are we still waiting for that to catch up a little?
Right. No, I think that's a great question. Again, it depends on how you define success.
Yep.
So we're seeing mortality rates decline. So I think that probably is the most important factor, right?
For sure.
We're diagnosing men earlier. That allows them to be cured earlier, rather than patients who may not come to us quite in time. Even for patients who have disease that's spread throughout the body, we call this metastatic prostate cancer. That unfortunately is typically incurable, but we can extend men's lives for years and years. And I have patients with metastatic prostate cancer who are alive 10, 12 years after their diagnosis. So that's very different than, of course, a lung cancer or a pancreatic cancer, where that would be uncommon.
Right.
So even for men with advanced disease, we can help them extend their lifetime, but clearly nothing beats cure and moving on with your life going forward.
Right. So get in early, another reason.
Exactly. So I think, again, screening is really the entree to that. And again, we've seen mortality decline. We've seen the rates of metastatic prostate cancer decline. This is across the United States.
Yeah.
Right. So this is the field, right? The field advancing. So all of these innovations that are occurring, and we're very hungry to grab onto these types of new innovations as quickly as we can that have been vetted. So again, there's many of us who are fellowship-trained urologic oncologists. We are meeting and presenting at meetings on a regular basis.
Yeah, I know you've done a ton of this stuff.
I do. I really enjoy this part of the practice, and I run our research program. So again, not only do we care for patients in that facet, we're performing research in areas of prostate cancer where we've been part of innovating new therapies in the world, right? And so again, these are the really enjoyable parts of our practice, is caring for patients hands-on, but also knowing that we're helping to advance the field. And so it's a really nice balance of both leading and also being people who are providing sort of the ground level care. And I think that's something that across the system we do a really great job of doing.
I want to just something, and I probably should have gotten to it earlier, but now is just as good. Is there a demographic? You mentioned ages a little bit, but we talked about family history slightly. Is there an individual who's watching this who should feel perhaps maybe even more motivated than others to come talk to you? What's the type of man, of individual who may be more prone to this?
Yeah. So again, I would say from the very beginning, any man can come to us and see us for prostate health evaluation, right? I have patients who come in where their complaint is, I just want a checkup.
Yeah, yeah,
and that's great.
Yeah,
come on in. Like I said, we'll talk about how you're voiding. We'll talk about erections. We'll give you some objective data. We'll often reassure you that, hey, listen, you're right in line with where you're supposed to be. We'll check your prostate if it's appropriate based on your age. We talked about family history, and the other major risk factor is being of African or Caribbean descent.
Okay.
So we are now learning, because of the advances in genetic testing, that there are some genetic abnormalities that are more unfavorable for prostate cancer that are more prevalent in populations of men who are either from Africa or Caribbean descent.
Okay.
And so that patient population kind of moves into a higher risk category. But in general, as I mentioned to you from the very beginning, just come, right? We'll kind of help you get in line. And as I mentioned, for many men, we provide that reassurance that, hey, actually, you don't need another test for 3 years or 5 years. It's like coming in for your colonoscopy and hearing, I don't know if you're back for 10 years.
Yeah.
It's a good feeling.
Yeah, that's great.
Right? You know you did the right thing and you know you're okay. And again, we like to do that, right? We like to sort of deliver that level of care. But again, age, family history, and race are probably the big three that matter for coming in a bit earlier than you might hear otherwise. But again, we sort of welcome that entree into the practice any way that you prefer to do it.
Dr. Prasad, this has been great. I can't tell you how much I appreciate you coming in to chat with us about this topic. I hope this program helps inform people, but ultimately there's reassurance in that too. And I think from all the stuff you've talked about today, from how we care for patients, the latest technology, sounds like our program is well positioned to help people out. So thanks for coming in and talking to me.
It's really my pleasure. Thanks for having me.
All right, folks, that's it for this episode of Community Conversations. But like I said in the very beginning, if you're looking for information on pretty much any other topic you can think of as it relates to your own well-being and your own healthcare, go to atlantichealth.org and check out the search bar, check out the Find a Doc tab, and then, of course, subscribe to our YouTube channel where programs like this are always available to you 24/7. On behalf of the whole team here at Atlantic Health, thanks so much for joining us, and we'll see you next time.